Good afternoon, everyone, and welcome to our webinar, Understanding HIV and STIs in BAME populations. We've got a couple of great speakers here today. We have muted the line. If anyone has questions throughout the presentations, you can use the Q&A function, which you should be able to see on your screen, and we'll try to answer as many of the questions as possible. We're going to start looking at HIV with Dr. Rageshri from Barts, who's an HIV and sexual health consultant. Thanks.
Thank you, Alex, and thank you to HIV Prevention England for this invitation to do the webinar. So as Alex said, I'm a consultant in sexual health and HIV, and I work in East London in Barts Health. And I normally start presentations with this painting, which is one of my favourites, by a London painter called Ed Gray. And the reason I show it is it shows Whitechapel, which is where I've been working for over 10 years. And you can see the Royal London Hospital in the background, and our clinic is part of that. And what you can see is that the population in Whitechapel is very diverse, and these are the kind of patients that I see in clinic, and it's the patients that have really kind of driven my interest in BAME populations and their needs. So we're going to talk today about epidemiology of HIV in BAME populations in the UK. I'm going to use a case presentation to talk about some of the issues, talk about barriers to care. I'm going to talk about impacts of institutional racism on health and health outcomes, ways forward, and just give some examples of good practice at the end. So first of all, what is BAME? So BAME stands for Black, Asian and Minority Ethnic, and it's a UK term and it's used in UK government policy. So it's only used here, it's not used elsewhere at all. And it's a fairly contentious term. Some people would like it, some people don't, and you may hear other terms like people of colour, for example. So how many people in the UK are termed as being BAME? Well, the last census in England and Wales in 2011 showed that 14% of the population, almost 8 million, were classified as being of non-white ethnicity. So so in terms of HIV and BAME populations, we can see that although BAME populations make up 14% of the population in the UK, they make up 74% of heterosexual men and women attending for HIV care. And in terms of new HIV diagnoses, they also still make up the majority of new HIV diagnoses, especially amongst Black African communities. And when it comes to new diagnoses amongst MSM, we can see that the recently reported fall in diagnoses amongst white MSM is not as pronounced amongst MSM from BAME communities. And lastly, looking at late diagnosis, which is the most important predictor of HIV-related mortality and morbidity, we can see that people of Black African heritage are more likely to be diagnosed late, which can have impacts on their future health outcomes. So I hope you can see from that data that in the UK, people from BAME populations are disproportionately affected by HIV, and that some groups are more affected than others. So for example, people of Black African heritage. So why is this important and why should we care? Well, we have the UNAIDS targets where we want to prevent new HIV infections by 2030, and we have the 90-90-90 targets, which I include the fourth 90 of quality of life being amongst them. And although we've made really great strides in the UK in terms of reaching the 90 targets, we have to think about who's not reaching those targets, who's being left behind, and who are the populations that don't have such good outcomes. And we really won't be able to reach those targets unless we address inequalities in terms of HIV care and access. And it's not only about targets, of course, this is also an issue of social justice and human rights as well. So I'm just going to start off with a case, and it's a case which is amalgamation of many, many people I've seen over the years, and not an unusual case for Whitechapel. So this is Imran, who's a 32-year-old Bangladeshi man, newly diagnosed with HIV, who'd never tested before. And his route into services was via his wife, who tested positive at the GP whilst having routine fertility testing. So he was seen in the HIV clinic with a Bengali interpreter, and he was fairly well. He had a history of depression for which he was taking citalopram, and he had been seen in the urology clinic for erectile dysfunction 3 years ago, and he took Viagra when needed. He didn't drink, smoke or take any drugs. And he'd moved to the UK aged 24 from Bangladesh. He had leave to remain and was applying for indefinite leave. He was working as a mechanic and was a practicing Muslim attending mosque regularly. He lived with his wife of 8 years and her parents, and they'd been unsuccessfully trying to conceive for several years now. He also said that he'd been having sex with men in saunas and used condoms rarely, and he described urges to have sex with men, and his history of erectile dysfunction was only with his wife. He also described a lot of mental stress from pressure from her family regarding their lack of children. Since his diagnosis, he had been speaking to his wife about his urges to have sex with men, and he requested in clinic to see a counsellor to cure him of these urges, as he wanted to be a good Muslim and a good husband. So on examination, there were no abnormalities, and we can note from his results that he was diagnosed late with a CD4 count of 280, and he was also positive for syphilis. So I wanted to talk about some of the issues that may impact on Imran with regards to his knowledge of HIV prevention and testing, his routes to accessing care, and impact on his health outcomes. So I'm going to talk first about sexuality. So Imran would not have called himself gay, and he comes from a culture where often homosexuality is seen as being taboo or not talked about or wrong. And we know that some people from some BAME communities come from cultures or countries where homosexuality is forbidden and even illegal. And all these issues can drive internalized homophobia, which can impact on people's access to testing and their knowledge around sexual health and HIV. Faith and community were really important to Imran, and he got a lot of support from them. So his faith was important to him. He felt good support from his community, being a migrant as well. It was important to have it there. But he did describe how having HIV and having sex with men made him a bad Muslim, and he also talked about the considerable community pressure on him to have children. So for many people from BAME communities, faith and community can be really good factors in terms of support and social isolation, but they can have negative impacts as well. And in terms of migration, Imran was a migrant. He was applying for leave to remain, which can be a very stressful experience. In terms of migration, often people who are migrants may not be able to work. They may be living in poverty, and this can all impact on their access or engagement in HIV care. And with the increasingly hostile NHS environment to migrants, this can deter people from turning up to clinic as well. And finally, language and stigma is important. So Imran comes from a community, from a culture where sex and sexuality and talking about it can be seen as taboo, and that may have limited his knowledge of sexual health, HIV prevention, and where to access services. And it's important to remember that Imran had never had a sexual health test before, never had an HIV test. He only turned up because of his wife. So all the campaigns around outreach testing, etc., had not reached him. It's important to note that. So what happened to Imran? Well, he started HIV treatment and was treated for syphilis, and he was told about U equals U and advised to have regular STI screening and use condom with casual partners. He did see psychology, but that was more focused on accepting his sexuality and not curing him. And he was referred to an HIV charity for peer support to address stigma and isolation. So Imran is a case which has highlighted some of the barriers that can exist for people from BAME communities to accessing and attending HIV care. So some of the barriers include, for example, not having good knowledge of sexual and reproductive health. And this can be due to not having access to comprehensive sex and relationship education, cultural taboos around discussing sex and sexuality, and getting information not from NHS sources or reliable sources, but just talking to friends, and that information may not always be accurate. There may be issues around health literacy, so not being aware of services that exist and knowing that they're free or how the health system works. And for example, you don't need to be referred to go to a sexual health clinic. There may be worries about confidentiality, so seeing someone you know from your community in the waiting room or knowing the receptionist, for example. There may be issues around language, so Imran, for example, didn't speak much English and an interpreter was needed. And as I mentioned before, in terms of immigration status, that may deter people from attending clinic because they may be worried about being detained or referred to the Borders Agency. We know that people from BAME communities have higher rates of poverty and unemployment, etc. And there may be structural barriers to attending clinic. So, for example, not having the time or the finances of coming to clinic, not finding someone to look after children, for example. And for an individual, HIV may be the least important thing to them at that time compared to other issues in their life. And also thinking about us, do we have clinics that are hard to reach? And, do we provide culturally insensitive services? So I'm going to talk a bit about that later on. I also want to talk about institutional racism, and I'm calling it the elephant in the room because I think it's something that we don't talk about often because it's an uncomfortable topic to talk about, but I think it is being discussed more. So institutional racism is a term that originated in 1967 from Carmichael and Hamilton, but became more known in 1999 in the UK because William Macpherson wrote the Stephen Lawrence inquiry. So he reported on the inquiry into the investigation of Stephen Lawrence's murder, and he used the term in that. So he described institutional racism as being the collective failure of an organisation to provide an appropriate and professional service to people because of their colour, culture or ethnic origin. It is seen in processes, attitudes and behaviour which amount to discrimination through unwitting prejudice, ignorance, thoughtlessness and racist stereotyping, which disadvantages minority ethnic people. So it's important to note that this is a failure of institutions and processes within institutions. And it's uncomfortable because often the vast majority of people don't go into work thinking they're going to be racist. Most people have good intentions and they want to do well by the people they serve. But it's important that we focus when it comes to institutional racism on outcomes. So what are the outcomes of well-meaning intentions and how may they impact on communities of colour? So looking at institutional racism in healthcare, there are many historical examples and I've listed only very few. So some examples of racism in healthcare include eugenics, which is most known about with regards to the Nazis in World War II. There's a history of forced sterilizations, many examples of this throughout the world. Also unethical research, so for example, experimentation with the Tuskegee and Guatemalan syphilis studies and the development of the oral contraceptive pill. And also, for example, grave robbery, so bodies of slaves were stolen and there was a trade in them so that doctors and medical students could do autopsies to gain medical knowledge. So it's really important that we acknowledge that a lot of the facts that we know in modern medicine come from exploitative and unethical practices which have impacted marginalised groups, especially people from BAME communities. So that's, I would say, is all in the past, but there are still lots of examples where we can say there's institutional racism in healthcare. So for example, there's lots of studies in the US that shows there's a racial bias in prescribing pain medication. So it's been shown that American doctors are more likely to give insufficient pain medication to people from African American and Hispanic backgrounds because they feel that they have, one example has been that they feel they have thicker skin, so they don't experience pain as much. And also they think they're more likely to become addicted to drugs, so they don't want that to happen, so they prescribe them less. More recently, in the UK, we've had reports of maternal death rates being 5 times higher for Black women than for white women in the UK. And in mental health, we know that people of Black African, Black Caribbean and Asian heritage are more likely to access mental health care through a criminal justice agency than via primary care or self-referral. And I've mentioned NHS immigration policies before, such as upfront charging. We know that if you are from a BAME community, you're much more likely to be asked for ID than if you're white. So what are the impacts of institutional racism on health? So as I've described, it can deter people from accessing or engaging with healthcare. It may lead communities to distrust or fear health services because of the historical situations. So for example, in clinic, it's not an uncommon conversation where someone might question why I want them to try a new antiretroviral. And they may ask me, is this a new drug? Are we experimenting on them? Even though the drug has been licensed for years. So people sometimes have an understandable distrust in us and healthcare services. And that may impact on recruitment and research as well. And institutional racism has lots of socioeconomic consequences which may impact on health and access to healthcare. So people from BAME communities in the UK are less likely to live in good quality housing or live in an area with good air quality. They're more likely to live in poverty with poor educational opportunities and more likely to be unemployed and less likely to be able to access healthy food and exercise. And all these things can impact on different aspects of health. And it's also important to note that there is emerging research that shows that exposure to daily discrimination and racism is a chronic stressor that can affect mental and physical well-being in itself. So how can we address racial inequalities in HIV care and better serve our BAME communities? So I sometimes think of a couple of theories when I have patients in clinic, and I just want to describe them to you. So the first one I think about is intersectionality theory, which was first coined 30 years ago by then law student Kimberly Crenshaw. So this is a theory which looks at structures of oppression, for example, sexism or racism, and it looks at how they overlap to impact on somebody's person's chances in life. So she first used it to describe discrimination that Black women face. So not only would they face sexism because they're women, but they may experience racism as well. So there's overlapping discriminations, and we can use other systems of oppression as well. When we think about this, we could add on homophobia, transphobia, HIV stigma as being all systems of oppression that may be impacting the patient in front of us. So I try to think about what are the structures that surround my patient and how might they be affecting their health. And just to say, it's being used a lot more in research as well. So I've just given an example of a study which looks at the social determinants of health for African American mothers living with HIV, which is quite an interesting read. Another model I use sometimes is the social graces theory, which comes from psychology. And this is a model looking at what makes up a person's identity, which are listed in that circle on the right. And it's important to know that these aspects are dynamic. So some may be more important to a person at some times than others. So again, thinking about the person in front of you in clinic, what is more important to them at that particular time. And how can we make our clinics more approachable, and how can we build trust of our patients? So we should make sure that our staff are aware of different cultural expectations and norms around healthcare. We need to make sure our policies on confidentiality are clear and provide interpreters, but again, reassure patients that even if the interpreter is from their small community, they have the same confidentiality rules as everyone else. We need to provide accurate information on the NHS and care of migrants and refer patients for advice where needed. And we need to think about specific clinical issues. So for example, malaria prophylaxis or antiretroviral interactions, and when traveling overseas, or fasting practices, for example, so how to time antiretrovirals. And we should be providing culturally sensitive psychological support. And then outside of clinic, we need to think about how to get patients aware of services and get them increasingly tested. So increasing access through sexual health education, doing mainstream and social media campaigns to specific communities, providing outreach HIV testing, for example, in barbershops or elsewhere, or faith communities. We should be encouraging support with, beyond clinics, so addressing HIV stigma and isolation with peer support, making sure we've got referral pathways for help and advice around benefits, housing and immigration, and also have some knowledge about where are the non-HIV community groups in the area which patients may want to access, again, to address isolation and mental health. It's also really important that we empower communities to create solutions for themselves. And one method of doing this is doing community-based participatory research. So really getting the communities themselves to say what questions are important to them and think about how to answer them. And then finally, I want to say that we need to look inwards as well. So instead of labeling communities as being hard to reach, what are we doing that deters people from engaging with care? What makes us hard to reach? So it's important to reflect on our own implicit and explicit biases. So we are all biased in some way. We are products of society and we reflect societal views. So it's important to realise that we are not really objective. We all have biases in some way. And some of the education that we have, medical education, also reflects society. And we need to think about what's on the curriculum and why. So again, that's not objective either. So I just wanted to give an example of some studies in the US that found that doctors were more likely to describe African American patients as non-compliant with their medication, so they had some bias towards them. So I think the question's really there is, why don't they comply? What are the reasons? So is it that they don't trust their doctors? Is it that they feel that the treatment hasn't been explained correctly? So it's really about changing that focus to us. And we really need to be aware of the power imbalances that we have with patients and how they may affect the way they engage with us. So what we can do to make ourselves more approachable, as we know that patients often don't tell us everything that's on their mind. So in conclusion, BAME populations are disproportionately affected by HIV at each stage of the continuum, from HIV prevention to viral suppression and quality of life. Important to realise that BAME populations are not a monolith. We need to avoid stereotyping and create personalised holistic management plans which aim to empower individuals to have the agency to look after their own health. And interventions aimed at specific communities should be led by those communities, and funding should reflect this. So I just want to end on this slide, which is just some examples of good practice, and there's many I haven't included. So just starting on the top right, there's the wonderful NAM, which does brilliant patient information leaflets, and they do them in different languages, and I find that invaluable on a weekly basis in clinic. There's on the left, there's a GMFA Me, Him, Us poster campaign aimed at Black MSM. NAS have done a campaign called Show Lay Love for South Asian MSM, and also created a film called Faces, which is to increase discussion around HIV and sex and sexuality in African communities. There's House of Rainbow, which is for people who have faith and are from LGBTQ communities. And finally, the excellent TED talk by Neka Lukwolo, previously of Dean Street, talking about PrEP for Black women. So I'm just going to end there. Thank you.
First now via the Q&A. Just give everyone a couple of moments in case you're typing anything. With regards to the case study that you presented, and there's a situation where you're not just talking to one person, but actually two people are finding out their diagnosis. Is there anything that you do differently, or that you have to think about in terms of confidentiality? Obviously, the situation in this case that you looked at regarding human sexuality, what sort of things do you ensure you're doing around that, those kind of aspects?
I think the most important thing is making sure that they see different clinicians, so keeping the care kind of separate. So I try and see couples and see expert cases in terms of confidentiality and things. I think that's really important, but also important that the clinicians involved in both people's care talk to each other so they can know what's going on.
I don't know if you know the answer to this. We've had a question around the NAS Faces film and where people can access that.
So that's a really good question. I don't know the answer today. I think probably the best thing to do is to contact NAS, but I will try and find out, and I will tweet about it on social media if I can once I've spoken to NAS.
And we've just got another comment here. More of a point than a question. It's refreshing to hear someone talk about institutionally racism and intersectionality theory. Thank you. And a question here from Tony. Is there anything specifically to mention around Latin American communities and HIV? We know that new diagnoses are twice as high now than they were 10 years ago within this emerging community.
I think that's a really important point. I haven't really talked about specific communities today because the presentation will be much longer, but I think, as you say, rates are going up increasingly, and I think there needs to be specific campaigns towards that community in terms of getting them to access testing and getting into the general community to talk about sexual health.
Thanks. We'll move on to our second presentation now, but if anyone has any other questions, keep them, we'll try and fit them in at the end. And I'd just like to introduce Fabian Cooken, who's an HIV and STI prevention scientist from Public Health England. Thanks for joining us.
Thank you for having me. So I will be presenting some data from Public Health England and other studies we've done on the sexual health in gay and bisexual men and other men who have sex with men, and Black, Asian and other ethnic minority populations in England. So just a list of the abbreviation that we'll be using throughout the presentation. So STI is sexually transmitted infection, GB, MSM is gay and bisexual men and other men who have sex with men. BAME is for Black, Asian and other minority ethnicity. UIA is for unprotected anal intercourse. GC is for gonorrhea. BC is for Black Caribbean. BA for Black African communities. M is for mixed ethnicities, WB for white British, and TB for Trichomonas vaginalis, sorry. So just an outline of the presentation. be talking in the first part about GB-MSM, and in the second part specifically about BAME populations. Just a warning before I start is that all the data, unless I mention it, is taken from level 3 services in England who report to the GUMCAT surveillance system. And so HIV clinic data and diagnosis are not included in those numbers in cases where the GUM and HIV services are commissioned separately. So first for GB-MSM, just for cases for the two main STIs, syphilis and gonorrhea. So since 2009 to 2018, syphilis numbers have increased by 236%, and while for gonorrhea it has increased by 642%. So quite a big increase. And so picking up on that, over the last decade, there's been a general steady increase in the number of STI amongst GB-MSM. And keeping gonorrhea as an example, while it was relatively infrequent, relatively infrequent diagnosis among GB-MSM in 2009, with about 3,500 diagnoses. Last year, it was the most frequently diagnosed STI with over 26,000 diagnoses. And now moving on to the data for last year's diagnosis in STI broken down by HIV status in MSM. So the total proportion of HIV positive who have been diagnosed with an STI last year was 18.6%. But we can see that for the syphilis diagnosis, actually, GB-MSM who are HIV positive actually represent 32% of the diagnosis last year, which is much higher than for other STIs. That is a graph showing the rate of gonorrhea and syphilis by sexual orientation and or HIV status over the last 5 years. So the top graph is for gonorrhea, the second one is for syphilis. And so the two main points here are that men who have sex with men who are HIV diagnosed, their rates of diagnosis is much higher than their HIV negative counterparts for both gonorrhea and syphilis, and it is similar for other STIs. And the other point to take away from this is that the scale for rates of diagnosis in MSM is so much more higher than it is for heterosexuals. So if taking gonorrhea as an example, rates are between 22 over 100 per 1,000 population in MSM, but in heterosexual, that number is still under 1 per 1,000. So quite a big difference there. Now, so that is a study that was done a few years back, the Gay Men Sexual Health Survey, that is currently underway as a new iteration of the study, so we'll be able to update those numbers soon. But that shows that from 2000 until 2013, the proportion of MSM that reported unprotected anal intercourse in the last year at the moment of the survey increased from 43% to 53%, quite a big increase there. And specifically what the graph shows is that a very small proportion of MSM who have significant high number of unprotected anal sex partner in the last year. Now moving to BAME population specifically, and the rates for STIs broken down by ethnicity as the first part. I'm going to use again gonorrhea diagnosis rate as an example. And so we can see that Black Caribbean, Black other, and mixed white and Black Caribbean ethnicity in both men and men have the highest rates of diagnosis in gonorrhea. And also that gonococcal rates are much higher in men than there are in women. So about 3 times higher, actually. And so what that raises is a question on why bacterial STI are so much higher in Black ethnic groups compared to other groups. And as you're aware, socioeconomic deprivation has influences on general and sexual outcomes. And so last year we did an analysis using the GAMCAD data, and it found that socioeconomic deprivation explains some, but not actually all, of the ethnic disparities in STI rates. And so there's definitely some unmeasured behavior factors that are contributing to those higher STI rates. With the rollout of GAMCAD v3, we're hoping that collecting some more behavioral data, we'll be able to find any other underlying factors that we can, at the moment, analyze for. So this is presenting some of the results of NatSal, so last iteration of NatSal, which ran from 2010 to 2012. And what that shows is that men of Black Caribbean background have the lowest median age of sexual debut. They also have the greatest median lifetime number of sexual partner. And they're also most likely to have had condomless sex with more than one partner in the last year. With Black African ethnicity men and mixed background men, they're least likely to be sexual competent at sexual debut. And Black African ethnic men are also more likely to report concurrent partners. Now looking at women specifically for the same study, it showed actually that mixed background women have the greatest median lifetime number of sexual partner. They're most likely to report concurrent partners. They're also most likely to have had condomless sex with more than one partner in the last year. Along with Black African women, they're least likely to be sexually competent at sexual debut. And with Black Caribbean background women and mixed, and white British background women, so they have the lowest median age at sexual debut. Moving on to a literature review that was published late last year. So that literature review looked at the association between bacterial STI, trichomoniasis, and ethnicity. And that included 15 studies that were set in the sexual healthcare setting. And what that showed is that there was a greater STI risk due to variation in socioeconomic factors and sexual behaviors like I've described before. But what we hadn't been able to collect is the fact that recreational drug use also has an effect. The prevalence of early sexual debut, concurrency, and multiple partners are also most common in Black Caribbean men compared to their white ethnicity counterparts. And also people of Black Caribbean ethnicity are more likely to be assessed in specialist sexual health services compared to their white counterpart again. Now looking at different breakdowns, instead of being by ethnicity, looking at the world region of birth. Taking gonorrhea again as an example, gonorrheal diagnosis rate over the last 5 years, we can see that people from Latin America, so Latin America includes Central and South America, and the Caribbeans, have the highest diagnosis rate for gonorrhea, but actually that's also reflected for chlamydia and syphilis diagnosis rates. And looking specifically at gonorrhea, actually, people from Central and South America, their diagnosis rates are about 10 times higher than they are for UK-born patients. So one thing to keep in mind is that one of the limitations of that data is that this is an indicator, but actually where people are born doesn't tell us what their citizenship is or how long they've lived in the UK either. But the good thing about this is that while we previously presented the total number of diagnoses, this graph here shows the underlying population of each of these subgroups. And we've never included that before, and that really emphasizes the disproportion of STI rates amongst various populations. Now looking at non-white GBMSM specifically. So here I'm not going to be presenting rates because the underlying population numbers that we get to do the calculations are taken from ONS data. And unfortunately, ONS data doesn't have a breakdown by gender or sexual orientation. So the only thing we could do is just to present the numbers here. As I've shown on my previous slide, my very first slide, is that gonorrhea is the most commonly diagnosed STI in GBMSM, which is why I've used it again here as an example, and it has increased nearly 7-fold since in the last 10 years. And so it shows here that in non-white GBMSM, Asian and other ethnicity have the higher number of gonococcal diagnoses. And I just want to add that Asian ethnicity includes the Chinese ethnicity, and that represents about 25% of the Asian ethnicity, of the other ethnicity. So just to go over the results. BAME sexual health, the bacterial STI rates are consistently higher in people of Black, Caribbean, and Black other ethnic groups, and in people born in Latin America and the Caribbean. And people of Black Caribbean, Black African, and mixed ethnicities are more likely to report concurrent or multiple partners. Just wanted to go over what PHE is doing to address those inequalities in the BAME population. So we are working with different organizations and academia on a number of initiatives to address those. And one of those is working with HIV Prevention England to promote amongst behavioral interventions, the condom use and the awareness of STI in the context of HIV acquisition and transmission. We'll also have an academic partnership with the National Institute for Health Research and Health Protection Research Unit on blood-borne and sexual transmitted infection, and that is to convey health promotion messages aimed at reducing the incidence of bacterial STI in MSM and also in Black Caribbean communities. Recently, we've published a syphilis action plan with recommendations with partner organizations to address the continued increased rates of syphilis diagnosis. And we are currently reviewing the results from the presentation to see what else we can do to address those issues and disparities. These are the contributors to the future BAME report that we are planning on publishing by the end of the year. And we would like to just thank you, all third-party, all third-sector organizations who I'm sure some of you are listening to this webinar. And we really appreciate the continued effort to make this report a reality. And we want to reiterate that a section of that report will be dedicated to those organizations in terms of they'll be taking part in writing a section on what interventions have worked so far that they've managed to put together. Thank you. And if you have any questions or comments, please feel free to.
Thanks, Megan, for that great presentation. We have a couple of questions. I think one of them came through for Rashi, and it was talking about if somebody's sexual orientation or behavior additional questions, you're welcome to.
Thanks. So I think that's a really important question and also a very difficult question. And I wouldn't say that's something that we would necessarily do in clinic or in healthcare. I think it's about signposting people to other people from their community who may, for example, be from the LGBT community. So a good example that would be Cholet Love, which is a project aimed at South Asian MSM. So I have, for example, signposted patients who are South Asian MSM who may be coming to terms with their sexuality and feel that it goes against their faith to that group, because then they can get some, it gives them access to peer support where they can really discuss those questions about their faith and how it impacts on their sexuality and their faith and how it impacts on them. So it's more about signposting rather than, I think, something that we can do in clinic necessarily.
I've got a few more questions. One of them is around the BAME report, and when is that going to be available? Do you have an idea?
So we're hoping to publish by the end of the year, and so I think what was run around was October and November, but there hasn't been any definite dates yet for a release.
Okay.
Yes, and then there was one that came in earlier where you were speaking, which was an anonymous attendee who expressed their concern that some services hypersexualize various groups, particularly Black groups, so Black and Black groups. And when talking about the language of risky sexual behavior, so the question was, how can services ensure that they're not stigmatizing groups while acknowledging the need for having targeted approaches?
Just repeat that, sorry.
Yeah. So how can services try and ensure that they aren't stigmatizing groups while still acknowledging the need for targeted approaches? And I think this is something for both of you. You have more of the clinical experience, and in terms of the messages that come out from the PhD data on the disparities or the research, like from the NATSO data that you just showed. How does our language tone that line?
That's a very good question. I wasn't necessarily aware of that personally, but I'm sure when we work on the report, when it will go around for comments, and also because we're involving community organization, that will be brought up. And so if there is an issue about the language mentioned there, that will definitely be addressed, and then I'm sure we'll be addressing both the language, but also give either recommendations or comments on how to best approach those issues.
I'd like to just add into that as well. So what you said about community organisations is really important. So making sure they're consulted at an early stage, and not only are consulted but are part of the whole process, I think is really important. And language is important. So we know that just from HIV, for example, I think language is changing. We're more aware about stigmatising HIV language. So I hope that's going to happen more with talk around sexual health and, you know, stopping using terms like risky in sexual health. I hope that will change.
Thanks. There's been a few questions just around the presentations. We will make them available when the webinar has been recorded, so you will be able to catch up with that afterwards and share with your colleagues if it's useful. Just a couple more questions. So, what are we doing to tackle cultural barriers to enable community engagement with these communities?
I think from a PhD perspective, what we're really trying to do, especially for this report, which I'm not sure we've done before, is just really trying to engage with community organization, like I've mentioned, because effectively those are the communities that are on the ground and that know where the issues lie. So that's the best way we could tackle those barriers.
And
No, that's fine.
There's another question. The concept of intersectionality is really important, but how can this be applied in a practical way when working with communities, especially when we're encouraged to disaggregate data in quite a simplistic way for monitoring and evaluation purposes?
So I don't think I have much knowledge about the monitoring and evaluation process in terms of what's required, so I can't comment on that. When I use intersectionality on a daily basis, I think about all the external forces that are affecting the individual in front of me. So all as I said, so the sexuality or their HIV status, for example. So I think that's quite a practical way of looking at those external forces that may impact on their health and their behaviour. I'm not sure about in terms of with communities, because it will be different for individuals within the communities.
Okay, thanks. And have we any other questions at all?
Did you answer the one about checking cultural barriers?
Yes.
Okay, yes. The rest are more around hearing, so I'll answer those prior.
Okay, thanks. Thanks, Dan, for joining us today. As I mentioned, we will be making this available online in the next few days with the presentations. I will also include some of the links to some of the best practice scenarios that we're going to be including that basis. Thanks. And if you want to keep in touch and find out about our upcoming webinars, if you visit the HPE website, which is hpeinternet.org.uk, and sign up for our newsletter, we'll make